In this video, we will discuss venous approach to treatment of arteriovenous malformation. This is the axial T2 MRI and sagittal T2 MRI, which shows ruptured arteriovenous malformation. This is the axial SW image, which confirms hemorrhage around the nidus. The IC injection shows a patchy nidus, and this is the oblique view, which shows multiple small feeders supplying the nidus. It appeared that none of these feeders are catheterizable. Therefore, we decided to go for a venous approach. This is the late phase, which again shows there are two veins which then join together to form a single vein, which in turn drains into the basal vein. Note the acute angle between the veins draining the AVM and the basal vein. This is the AP projection, again shows a patchy nidus with multiple small feeders supplying the nidus. This is the late phase, which again shows both these veins joining to form a single vein. The approach would be to place a large bore 088 Cerebase guiding catheter right at the proximal part of the straight sinus. Following this, we would place one of the onyx microcatheters in the superior vein, followed by which we will place the other catheter in the other vein, which is draining the AVM. Here we used a headway duo onyx microcatheter. Following this, it is important that we arrest flow in the arterial system, for which we place two balloons, one balloon in the P2PC as marked by the green arrow and the other balloon in the M1MC as marked by the blue arrow. We drop the blood pressure to nearly 60 or 70 systolic during the onyx injection. The idea is to inject onyx such that the veins get filled up first, following which the onyx percolates into the nidus and thereafter into the arterial feeder. Notice the Cerebase microcatheter guiding, that is in the straight sinus. Normally we do a jugular puncture because we'll have to cut these microcatheters at the neck. We don't use a detachable catheter as it can cause potentially stretch injury to the veins. You notice a guiding catheter in the arterial system to place the balloons. Both microcatheters are in place. Always there is a problem when you navigate from the basal vein into the veins draining to the AVM, as there is an acute angle. This is the AP projection showing both microcatheters in place and both balloons in place and inflated. Once the balloons are inflated and blood pressure is dropped, we start the onyx injection from both the microcatheters. First, the onyx will fill the veins, and thereafter there will be an retrograde penetration into the nidus. So we keep injecting until the nidus is filled with onyx, and thereafter there is some arterial feeder that is seen being filled with the onyx. And this is the post-procedure injection, which shows complete obliteration of the nidus. It is important to keep the patient intubated for the next 24 hours. Repeat a CT at maybe 3 to 4 hours and 24 hours later. Keep the blood pressure lower on the lower end, and if all goes well, then you extubate the patient. This patient did extremely well and was discharged 4 to 5 days after the procedure with careful monitoring of blood pressure. Thank you.